Hello everyone. Let's talk about perioperative bridging for anticoagulation. In today's daily hematology bleep, you may be receiving a lot of bleeps regarding peri-op bridging or pre-op bridging, about the patients taking anticoagulants. The guidelines are very clear about DOACs and warfarin, but there are some situations which are a bit tricky and about which guidelines are not clear and not present. In that case, my advice would be to follow your trust guidelines and trust recommendations. My trust recommendations may be a bit different than your trust recommendation, and you may not agree with that. So, whenever you appear in the exam, always say, according to my trust policy, I will do like this and that, then you will be saved in the exam. But if there is any national guidelines regarding anything, then in the exam you have to mention the national guidelines. For example, you may receive questions that the patient is going for cataract surgery or tooth extraction. Patient is on warfarin. What should we do? In these minor procedures, it is okay to continue warfarin. There is no issue with the warfarin. No need to stop the warfarin before the minor procedure like single tooth extraction or skin biopsy or soft tissue injections, etc. But if the patient is going for a major surgery and it is an elective surgery, then you need, and the patient is on warfarin, then you need to take into consideration two things. Is there any special situation with this patient, or this patient is having warfarin for routine normal conditions since long time? From the special situation, I mean that if the patient has any um, VTE in the last 3 months, um, if the patient has any TIA or stroke within the last 3 months, or if the patient has any um, mechanical heart valve other than bileaflet aortic valve. These are the special situations in case of warfarin where you need to consider pre-op bridging. So ask the caller whether your patient has any, ask him why he is using or why she is using warfarin. The caller will tell you this patient is using warfarin because of mechanical heart valve or atrial fibrillation or recent VTE or VTE. So ask him if there is any recurrent VTE on warfarin, or um, is there any VTE in the last 3 months, or if the patient is using it for AF, is there any history of stroke or AF in the last 3 months? If the patient has AF, then you need to consider other comorbidities as well, like congestive cardiac failure, hypertension, the age above 75, and diabetes mellitus. Hypertension is on medication. Okay, so if three of these four comorbidities are present, so then they become very high risk patients and they will need pre-op bridging with warfarin. So which are the three category? Any patient with mechanical heart valve. Second one, any patient with VTE in the last 3 months and on warfarin. And third one, any patient with atrial fibrillation and has stroke and TIA in the last 3 months. These are the three cases of warfarin which need pre-op anticoagulation with low molecular weight heparin. All other cases of warfarin need stopping on day -5. The last dose will be day -6. Then the patient will not take any warfarin. Day -1, you can check INR. In some hospital, they check INR in day -2. If it is high, then they can correct it and repeat INR on day -1. And before surgery, yes, you have to check the INR as well on day 0. But for that about three condition that we have discussed, there is no um, there is no pre-op anticoagulation except for the three conditions that we have mentioned. Okay, every trust has some pre-op guideline for warfarin, both for normal patients and for special patients. Special patients mean the one with having VTE in the last 3 months and on warfarin, having stroke in the last 3 months and on warfarin for AF, and having mechanical heart valve. So better to refer to your guideline. Most of the trusts that I have seen, they have given the pre-op bridging for warfarin in the form of table. It should be easy for you. Post-op bridging um, in normal patients are taking warfarin for atrial fibrillation, not a high risk one. Patient has stopped warfarin on day -5, and surgery has been done. What to do with the warfarin? So in this category of warfarin patient, you will start um, low microwave heparin on the day of surgery, 6 hours after the surgery. Day +1, low microwave heparin prophylaxis plus warfarin, twice the normal dose. A patient is taking 6 milligram per day. Usually, you will give him a 12 milligram dose on day +1. Day +2, prophylactic low microwave heparin and normal dose, usual dose of warfarin. Then day +3, again low microwave heparin prophylaxis and warfarin usual dose. Day +4, check INR. If it is in range, stop low microwave heparin. If it is not in range, continue low microwave heparin plus warfarin usual dose for another day. Okay. And then if you have a special situation where um, you did a pre-op where you did pre-op bridging for high risk condition on warfarin, uh, in those cases you have to give these patients low molecular weight heparin prophylaxis 6 to 8 hours after surgery on day 0, um, and nothing else. Day +1, you will give this patient prophylactic dose of low molecular weight heparin plus warfarin, twice the normal dose. Day +2 of the surgery, low molecular weight heparin prophylaxis, warfarin normal dose. Day +3, low molecular weight heparin therapeutic dose, split dose. If, for example, if the therapeutic dose of the patient comes out to be 16,000 units, tinzaparin, split it 8,000 morning, 8,000 evening, plus warfarin usual dose. Day +4, low molecular weight heparin therapeutic dose, split dose, and warfarin normal dose, plus check INR, and then act accordingly. If INR is in range, stop low molecular weight heparin. If INR is not in range, subtherapeutic still, on lower side, give another dose of low molecular weight heparin in the form of split dose next day, along with usual dose of warfarin, and check INR. So this is the post-op bridging for warfarin in special situation. Okay, so there is difference in the dosing of low molecular weight heparin in normal warfarin patient and in special warfarin patient. In normal warfarin patient, you do post-op bridging with prophylactic doses all the time. In post-op, in special situation, you do post-op bridging initially with low molecular weight heparin prophylactic dose and then therapeutic split dose. Okay, so this is the difference between normal warfarin patient and special warfarin patient. Who are the special patient? Who had VTE in the last 3 months on warfarin, who had AF and had a stroke in the last 3 months, who have mechanical heart valve. These are special patients which require pre-op bridging and post-op bridging as well. Other warfarin patient does not need pre-op bridging; they need only post-op bridging with prophylactic low molecular weight heparin. Now the question comes to the DOAC. Rivaroxaban, apixaban, and edoxaban, dabigatran. There are no guidelines for pre-op bridging in DOACs anticoagulation. All the practice is individual based and depends on the trust policy. Different consultants may have different opinions. Different hospitals may have different policies as well, because there is no clear-cut guidelines about DOAC pre-op anticoagulation. Normally, pre-op bridging is not required in DOACs anticoagulation. We stop them 24 to 48 hours before procedure, depending upon the nature of surgery and bleeding risk. And in case of dabigatran, 72 to 96 hours before surgery, depending upon the nature of surgery and bleeding risk. But in general, if um, if the patient has low bleeding, low thrombotic risk, okay, then we do not do any pre-op bridging in them. But if the patient thrombotic risk is high, then we consider um, pre-op bridging in DOAC population as well. And this is case by case based decision. Okay, these are case by case based decisions. For example, if you have a patient on DOAC, apixaban, and he has a history of recurrent VTE, this patient is a high risk for thrombosis. Interrupting apixaban is a high risk situation. Then we give them low molecular weight heparin bridging. Another case, if your patient has VTE in the last 4 weeks and he is going for surgery, and that surgery cannot be delayed for any reason. For example, your patient has a DVT and you have started the patient on apixaban. For some reason, you did a CT scan for this patient and it shows a pelvic mass. The gynae think that this may be a cancer. I want to do biopsy for this patient. No one will delay this biopsy because we are worried that this patient may have cancer over there. So this is a situation where you will think about pre-op bridging in this patient, although although the patient is on apixaban or DOAC. Then another case, patient has a DVT and a patient has a CT scan abdomen for some reason. There is a pelvic mass and there is a deep vein thrombosis as well in the tummy. You have started the anticoagulation for this patient with DOAC, and 5 days later, the gynecology consultant have decided, or their MDT have decided that we want to biopsy this patient. Then what to do now? Okay, in that case, the option is to give this patient either unfractionated heparin and then go for biopsy, or IVC filter is a bad idea. No one likes it because of the complication. So these are the three conditions. If the patient has recurrent VTE, if the patient has VTE in the 4-week time, and the patient has a VTE plus pelvic mass or some mass that need urgent biopsy, that would be the 3 situations where you would need peri-op bridging and patient may be using DOACs. Okay, so these are the 3 conditions, and they are not given anywhere. They are case by case decisions. If you have a hemostasis consultant in your hospital, ask them these 3 scenarios, what they would do. They would say, yes, we would give this patient bridging. And some of the hospital, they use enoxaparin or tenzaparin when they stop warfarin or when they stop DOAC in all patients. And then as a pre-op bridging. Okay. So read your trust guidelines, ask your hemostasis consultants and their experience what they would do if a patient has recurrent VTE and patient is on DOAC and he would go for patient is going for surgery, whether the consultant would do pre-op bridging or not. Me, yes. Ask your consultant, hemostasis consultant, if a patient has a VTE in the last 4 weeks, patient is on DOAC and going for any biopsy or procedure, whether he would like to do pre-op bridging in this patient or not. Me, yes. Ask your consultant that the patient has a DVT, deep vein thrombosis, along with a mass, and the parent team want to do biopsy for this patient. So this patient has uh, this patient has a DVT a few days ago, and he's on DOAC because there is no symptoms, no signs. Patient is not very unwell that the patient is on low-molecular heparin, but he has DVT or thrombosis few days ago, 2 days ago, 3 days ago. Now patient is going for biopsy. What should I do? Okay, whether this patient need pre-op bridging? If you ask me, yes. How pre-op bridging are done in DOACs? Again, depends on trust to trust and consultant to consultant. I will tell you my experience here only. Okay, so if a patient is on DOAC and he is going for a surgery which has a high bleeding risk, then we usually stop DOACs 48 hours before the surgery. And because of high thrombotic risk as well due to recurrent DVT or recent DVT, VT, etc., I will give this patient therapeutic dose of low molecular weight heparin on day -2, prophylactic dose on day -1, and day 0 he will be having surgery. Okay. If the patient is stopping DOAC 24 hour before the surgery, because the procedure is a minor surgery, then I would give this patient or advise this patient to stop your to convert your DOAC to low molecular weight heparin again on day -2, day -1 prophylactic dose, and on the day 0 nothing. Post-op, 4 to 6 hours after the surgery, first prophylactic dose. In minor cases, I can restart DOAC after the 24 hours after the surgery. In major cases, after the first prophylactic dose, I can give him therapeutic dose post-op, and then 48 hours after that, I can start the DOAC in the patient. So it is case-to-case base. Post-op bridging in DOAC is easy. You initially give them low-molecular heparin and then convert to DOAC. It is fine. It is clearly mentioned in the BSH guidelines as well. But the problem is in the pre-op case and high thrombotic risk cases where the patient is on DOAC. Okay. So I hope this discussion makes some sense. But again, I would advise to go to your hemostasis consultant and ask their experience. Open your trust intranet and open the trust guidelines and see what they have written about warfarin in normal situation, warfarin in special situation, and what is the post-op bridging in situation in normal warfarin situation and in special warfarin situation. Then look for the guidelines for the DOACs, what they have written in high thrombotic risk cases, what they have written in normal thrombotic risk cases. and DOACs in special situation like recurrent VTE, recent VTE, and very recent VTE. Like a few days back, the patient has VTE, and now he's going for mass biopsy to rule out the malignancy. So this was a talk about pre-op we will be having some small talk like this, where I will be telling you my experience and my consultant experience, and that I am learning from them. And your feedback is welcome. You can post the comments in the WhatsApp group or comments here as well. And I know this is coagulation. People views may be different, and we know that. Uh, every coagulation consultant has a different view from the other one in the same hospital and from trust to trust, from hospital to hospital. All your views are income. Some of the decisions in coagulation they are made on experience basis. There are not no clear-cut guidelines uh, in the coagulation for some topic. So we have to take decision in patient best interest. Thank you very much.